A surgical recommendation is not a final verdict. That is the single most vital sentence I want you to remember from today's video. Write that down right now if you need to, because after spending 21 years specializing in senior health, I have watched far too many adults over 60 hear a surgeon say, "You need an operation," and treat that statement like an unchangeable decree, as if their future has already been settled and is no longer open to question. It is not a verdict. It is simply the beginning of an important conversation. Knowing how to navigate that conversation, what questions to ask, what risks to uncover, and what non-surgical alternatives to explore can be the exact difference between a procedure that restores your independence and one that permanently takes it away. Here's the honest reality that most surgical consent forms fail to explain clearly. For adults past the age of 60, the greatest danger of an operation is usually not the time spent on the operating table. Modern surgical techniques, advanced monitoring, and contemporary anesthesia have made the actual operation safer than ever before in human history. The true, defining risk, the one that decides whether someone who walks into the hospital independently walks out independently, is surviving the recovery. What happens to an aging body during the weeks and months following major surgery is where patient outcomes dramatically diverge. And that divergence is shaped by biological factors unique to older adults that many surgical teams simply do not evaluate with enough precision before recommending an operation. My name is Dr. Eduardo Perez Alba. I've spent over 2 decades specializing in geriatric medicine and senior health. Today, I'm going to guide you through 5 specific surgeries that carry hidden, underexplained risks for older patients, along with the precise steps you can take to protect yourself before, during, and after any surgical recommendation. Make sure you stay with me through all 5. Surgery number 4 will surprise you because it involves a procedure most people view as completely routine. And surgery number 5, our final one, completely reframes how we must evaluate medical risk past age 75, changing how you approach every healthcare decision moving forward. If you are new to this channel, go ahead and subscribe right now. This is our core mission here, providing calm, honest, evidence-based medical guidance so you can understand your healthcare choices long before a high-stakes emergency forces the conversation. Let us get started. Before we break down the 5 specific surgeries, you need to understand one foundational concept. Without it, the individual risks for each operation won't connect into an actionable picture you can actually use. I call this concept the recovery gap, and it explains why surgical outcomes in older adults diverge so sharply from younger patients in ways the operation itself cannot predict. After age 60, 3 specific physiological changes fundamentally alter how the human body handles the trauma of major surgery. First, your physiological reserve naturally declines. Physiological reserve is your body's backup battery, the spare capacity of your heart, lungs, kidneys, and immune system to absorb massive physical stress and successfully return to baseline function. A healthy 40-year-old typically has an enormous reserve. Their heart can easily surge its output. Their kidneys rapidly clear anesthetic medications and metabolic waste. And their immune system heals the surgical wound without becoming exhausted. Past age 70, that reserve is considerably narrower. It is certainly not gone, but it is tighter. A physical stress that a younger body shrugs off without lasting harm can push an older body past its functional tipping point into a prolonged, incomplete recovery. Second, the body's inflammatory response becomes much harder to regulate. Every surgical operation creates a significant inflammatory event, a process necessary for initial wound repair, but dangerous if it becomes systemic and chronic. In older adults, that post-surgical inflammatory response tends to be both far more intense and significantly prolonged. Blood markers of systemic inflammation, such as C-reactive protein and interleukin-6, spike higher and remain elevated for weeks longer in seniors compared to younger adults, driving post-operative complications like delirium, delayed wound healing, heightened infection rates, and severe cardiovascular strain. Third, and this is a reality rarely highlighted in standard consent discussions, cognitive vulnerability during and after anesthesia is a very real, underappreciated risk. Postoperative delirium affects between 15% and 50% of adults over 65 following major surgery, depending on the complexity of the procedure and baseline brain health. Delirium, which manifests as acute confusion, severe disorientation, and sudden behavioral changes, is not a harmless temporary side effect. It is clinically linked to longer hospital stays, higher post-op complication rates, accelerated mental decline in patients with mild memory loss, and a measurable increase in one-year mortality. Crucially, it frequently strikes older adults who showed zero signs of cognitive impairment before surgery. Here is how the recovery gap plays out. A major surgery triggers severe inflammatory and anesthetic stress that an older body struggles to regulate. That stress sparks post-operative delirium or prolonged weakness, which leads to weeks of bed rest. That immobility rapidly causes severe muscle wasting and cardiovascular deconditioning, making physical therapy agonizingly difficult. And ultimately, a person who walked into the hospital fully independent leaves in a wheelchair, unable to live alone. Keep this recovery gap in mind as we evaluate each surgery on our list today. Let me ask you an honest, personal question. Have you or someone in your family ever undergone an operation described by doctors as routine, only to find that the subsequent recovery was far longer, more painful, and more debilitating than anyone prepared you for? Have you watched an aging parent or spouse go into surgery in reasonable health and emerge on the other side diminished in ways that were never explained beforehand? The vast majority of people I speak with have either lived through that exact scenario themselves or watched it happen to someone they love, and almost all of them express the same regret. They wish someone had explained what recovery would actually look like, and they wish they had known the right questions to ask before signing that consent form. That is precisely why we are having this conversation today. Here is what I need you to hold on to. Understanding surgical risks is never the same as refusing necessary medical care. Several of the operations on today's list are genuinely life-saving and completely appropriate for the right patient at the right time. Our objective is not to avoid all surgery. It is to ensure that whenever you or a family member faces a surgical decision, it happens only after a fully transparent conversation about the unique risks, the viable non-surgical alternatives, and the pre-operative preparation needed to secure a great outcome. That conversation is your fundamental right as a patient, and today you will learn exactly how to lead it. Before we go deeper, I've created a free longevity guide that outlines how to prepare your body for medical procedures and build physical resilience as you age. It is linked in the description box below. Grab your copy now and follow along. Let me explain the biological mechanism that makes surgery uniquely complex after 60, because this principle applies to every operation we will discuss. Think of your body's recovery capacity like a financial bank account. Every person has a specific balance in that account, funded by their baseline physical fitness, muscle mass, heart and lung health, nutritional status, and organ reserve. Whenever a major trauma occurs, like an infection, a severe fall, or a surgical operation, the body makes a massive withdrawal from that account to pay for healing. In a younger person with a large balance, that withdrawal is easily absorbed. The account replenishes quickly, and the body returns to 100%. In an older adult, particularly someone managing chronic health conditions, the starting balance is already significantly lower before the surgery even begins. Years of taking blood pressure medications, managing fluctuating blood sugar, or experiencing muscle loss during sedentary periods have made continuous small withdrawals over time, leaving a balance that is fine for daily life, but dangerously low for surviving a major surgical recovery. When that physiological account runs critically low after surgery, the body is forced to make desperate biological trade-offs. It may prioritize closing the surgical incision at the expense of immune defenses, dramatically increasing infection risk. It may break down precious muscle protein for emergency fuel if post-op nutrition is poor, rapidly accelerating muscle wasting. Or it may fail to control post-surgical inflammation, leading to persistent delirium, vascular strain, or heart failure. General anesthesia introduces another distinct challenge. It works by temporarily shutting down higher brain functions to make invasive surgery painless. But an aging brain, especially one with subclinical vascular changes or subtle memory vulnerabilities, recovers from that pharmacological suppression much more slowly than a younger brain. The flood of inflammatory cytokines produced by major tissue cutting can breach the blood-brain barrier in vulnerable older adults, causing persistent cognitive deficits. Research in the British Journal of Anesthesia confirms that post-operative neurocognitive disorder, marked by lasting drops in memory, executive function, and mental processing speed, occurs in a notable percentage of older surgical patients. While many recover over several months, for patients with pre-existing vulnerabilities, those cognitive losses can become permanent. Understanding this biological mechanism is what makes our list of 5 surgeries so crucial to examine. It isn't that surgery is inherently bad for seniors, but for these 5 specific procedures, the gap between what patients expect and what clinical evidence shows is at its widest. Surgery number 1. Open heart valve replacement in frail older adults. Take the case of Howard, a 78-year-old who had been managing moderate aortic valve stenosis for years. When routine echocardiograms showed that his valve narrowing had become severe, his cardiologist referred him to a cardiac surgeon. The surgeon reviewed the scans, noted the valve blockage, and recommended traditional open heart surgery to replace it. Howard's family, terrified by the word severe, immediately agreed to proceed. What the pre-op discussion failed to evaluate was that Howard's clinical frailty score placed him in a high-risk category, where an open sternotomy and heart-lung machine carried an enormous likelihood of the very complications they were desperate to avoid. Most people assume that if a renowned specialist recommends surgery, they have already carefully weighed the patient's age and full body resilience. Unfortunately, that assumption is frequently wrong. Surgical recommendations are often driven primarily by mechanical or anatomical findings, the tight valve, the blocked artery, the degenerated disc, without a standardized, objective assessment of whether the patient possesses the physical reserve to survive the recovery process intact. Clinical frailty is not the same as chronological age. A 78-year-old can be physically robust, while a 65-year-old can be clinically frail. Frailty is a distinct medical syndrome defined by depleted physiological reserve, unintentional weight loss, muscle weakness, exhaustion, and low physical activity. When formally measured using validated clinical tools like the Clinical Frailty Scale or the Fried phenotype, frailty is one of the single strongest predictors of surgical failure, far more predictive than age alone. Research in JAMA Surgery analyzing cardiac procedures in older adults showed that frail patients suffered significantly higher rates of in-hospital death, major post-op complications, and permanent loss of physical independence compared to non-frail peers of the exact same age. For aortic valve disease specifically, there is now a proven, minimally invasive alternative for high-risk patients: transcatheter aortic valve replacement, or TAVR. TAVR replaces the diseased valve through a small catheter inserted in the groin, rather than cracking open the chest, carrying a dramatically lower recovery burden. Landmark clinical trials published in the New England Journal of Medicine have repeatedly proven that TAVR delivers outcomes comparable to open surgery in high-risk patients, while drastically reducing procedural trauma. Here is your practical guidance. If open heart surgery is proposed, formally request a comprehensive frailty assessment first. Ask your cardiologist directly whether a less invasive catheter-based approach like TAVR has been thoroughly evaluated for your specific anatomy. This is not refusing treatment. It is asking for the complete clinical picture. Never assume all alternatives were ruled out simply because open surgery was suggested. Ask the question directly. Our next surgery involves an entirely different area of the body, yet the exact same balance between recovery burden and actual benefit applies with striking clarity. Surgery number 2. Aggressive spinal fusion for chronic lower back pain. Consider Evelyn, a 71-year-old who had dealt with persistent aching lower back pain for years. While not completely debilitating, it limited her daily activities. An orthopedic spine surgeon reviewed her lumbar MRI, pointed out degenerative disc disease and spinal stenosis, and recommended a multi-level spinal fusion, an extensive procedure where multiple vertebrae are permanently joined together using metal rods and screws to stop motion at the painful joints. Most people suffering from chronic back pain assume that major surgery will provide the permanent relief that conservative care failed to deliver. For specific structural conditions, such as spinal fractures, progressive nerve compression, or severe instability, that assumption can be true. But for non-specific degenerative changes, the routine wear and tear that shows up on almost every MRI of adults over 60, the evidence tells a very different story. Extensive Cochrane reviews and studies in the Spine Journal show that for degenerative disc disease and non-specific chronic back pain, spinal fusion produces outcomes no better than intensive, structured physical therapy and pain rehabilitation, while exposing patients to vastly higher surgical risks. The complication rates for multi-level spinal fusion in adults over 65 are substantial, including deep surgical infections, hardware failure, persistent chronic nerve pain, and adjacent segment disease, where the unfused vertebrae directly above and below the stiffened fusion bear extra mechanical load and degenerate rapidly. Now, for spinal stenosis specifically, narrowing of the spinal canal causing leg pain and walking limitations, decompression surgery alone has strong evidence for restoring mobility. But there is a massive difference between simple decompression, shaving away bone to free the pinched nerve, and spinal fusion, locking the bones together with hardware. Adding fusion to decompression should only happen when true structural instability is present, not simply because age-related disc wear appears on an MRI. Here is your practical guidance. Before agreeing to spinal fusion, ensure you have completed a dedicated, supervised course of targeted physical therapy under a therapist specializing in spinal rehabilitation, not just generic home stretches. Ask your spine surgeon what percentage of their patients with your exact diagnosis achieve lasting, meaningful pain relief from fusion versus non-surgical programs. And ask specifically whether a simple decompression alone could resolve your symptoms without adding the massive trauma of spinal hardware. The common mistake is confusing an MRI finding with an automatic reason for surgery. Age-related degenerative disc changes are present on the MRIs of nearly all adults over 60, whether they have pain or not. The scan merely shows an image. Whether that image represents the true source of your pain requires deep clinical judgment and thorough discussion. Let me pause for a second. Has a doctor ever taken the time to explain the difference between what shows up on your MRI scan versus what is actually generating your physical symptoms? Drop a yes or no in the comments below. This is one of the most critical, yet least explained concepts in all of musculoskeletal medicine. Surgery number 3. Major cancer resection, particularly the Whipple procedure for pancreatic cancer. This category requires extreme care because the clinical stakes are life and death. Major oncological surgeries, like the Whipple procedure for pancreatic tumors, pneumonectomies for lung cancer, or major liver resections, are undeniably life-saving in the right patient. But in a frail patient with limited reserve, the surgery can become the defining event that ends quality of life without meaningfully extending it. Take Vincent, a 74-year-old who was diagnosed with localized pancreatic cancer. A surgical oncologist recommended the Whipple procedure, an immense 8-hour operation that removes the head of the pancreas, part of the small intestine, the gallbladder, and portions of the bile duct. Vincent was never told that the 90-day mortality rate for the Whipple procedure in older adults with chronic medical conditions is substantially higher than in younger cohorts, or that the grueling post-op recovery might leave him too physically weak to tolerate the follow-up chemotherapy that provides the majority of actual long-term cancer survival. The issue is never that cancer surgery is wrong for seniors. It is that the decision demands an honest, multidimensional evaluation of 3 crucial factors. First, does the patient have the physiological reserve to survive both the massive surgery and the intense recovery period before starting chemotherapy? Second, is the realistic survival benefit, measured in months or years, worth the immense physical toll given the patient's baseline health trajectory? Third, will the remaining quality of life following major organ removal be acceptable to the patient? Data from the National Cancer Database confirms that among older, frailer patients undergoing major cancer resections, the gap between expected and actual outcomes is wide, characterized by prolonged ICU stays, high rates of missing life-extending chemotherapy due to post-op debility, and low rates of ever regaining pre-surgery independence compared to robust patients. Here is your practical guidance. If major cancer surgery is proposed, request a comprehensive evaluation by a geriatric oncologist or a specialized geriatric cancer assessment team before deciding. These specialized teams systematically assess frailty, functional stamina, cognitive health, social support, and nutritional status to predict surgical risk accurately, frequently. Identifying situations where less invasive therapies, like targeted radiation, immunotherapy, or palliative care, offer a vastly superior quality of life and survival balance. The common mistake is assuming that the surgeon who diagnosed the tumor has automatically conducted a deep evaluation of your full body frailty and biological recovery capacity. Surgical oncologists are trained to resect tumors. A formal geriatric risk assessment is a distinct evaluation that rarely happens unless you actively request it. Now, let us turn to an area where the principle of the recovery gap intersects directly with the elective choices most adults over 60 are most likely to encounter personally. Surgery number 4. Elective hip and knee replacements in medically complex or frail seniors. Let me state clearly up front, joint replacements are among the most successful, life-enhancing elective procedures in modern orthopedics. For a well-selected patient whose mobility is crippled by arthritis, who has exhausted conservative therapies, and who is medically resilient enough for surgery and physical rehabilitation, joint replacement delivers remarkable, durable pain relief and restored mobility. But the phrase, well-selected patient, is the entire point of this discussion. Consider Frances, a 76-year-old woman suffering from severe knee osteoarthritis that made walking painful and stairs impossible. She was also managing congestive heart failure, type 2 diabetes with peripheral vascular disease, and stage 3 chronic kidney disease. Her orthopedic surgeon, focusing strictly on her worn-out knee joint, recommended a total knee replacement. What the pre-op workup overlooked was that Frances's combination of chronic illnesses placed her at an exceptionally high risk for severe complications. Post-operative heart strain, surgical wound breakdown due to poor vascular blood flow, kidney injury from clearing anesthetic medications, and post-op delirium that completely derailed her physical therapy rehabilitation. A major systematic review in the Journal of Arthroplasty revealed that total comorbidity burden, the cumulative weight of multiple chronic conditions, is a far stronger predictor of joint replacement failure than chronological age alone. Patients managing 3 or more significant chronic conditions experienced dramatically higher rates of systemic complications, extended hospitalizations, and failure to regain functional mobility compared to medically stable peers. Here is your practical guidance. Before scheduling an elective joint replacement, take the time to optimize every single chronic health condition. The word elective means scheduled, which means you have time on your side. Ensure your blood sugar is tightly managed, because an elevated HbA1c directly multiplies your surgical infection risk. Ensure heart failure is completely stable. Have your nutritional status evaluated, because subclinical protein malnutrition is common in seniors and directly impairs surgical wound healing. A comprehensive preoperative evaluation by a geriatrician or pre-op optimization clinic can identify and fix these hidden risk factors long before you enter the operating room. The dangerous mistake is assuming the word elective means low risk. Elective simply means it is not an emergency. Using that preparation window to optimize your blood sugar, heart health, and muscle mass is the single most evidence-based action you can take to guarantee a great outcome. Now we arrive at the surgery that changes the conversation completely. The scenario where everything we've discussed today becomes most urgent because, unlike elective procedures, this category rarely allows time for planning. Surgery number 5. Emergency abdominal surgery in adults over 75. This category encompasses acute surgical emergencies, a ruptured abdominal aortic aneurysm, a perforated bowel from severe diverticulitis, an acute bowel obstruction, or perforated ulcers requiring immediate laparotomy. Here's what makes emergency abdominal surgery the most dangerous scenario on our list. It strikes under conditions that completely strip away the time needed for preoperative optimization, planning, and calm deliberation. The patient is critically ill, decisions must be made in minutes. Family members are in shock and under extreme emotional pressure, and underlying chronic conditions must be managed simultaneously with an acute surgical crisis. The clinical data for emergency abdominal surgery in adults past 75 is sobering. Studies in the British Journal of Surgery document 30-day postoperative mortality rates ranging from 15% to 35%. Climbing significantly higher in frail patients. For patients over 80 undergoing emergency laparotomy, one-year mortality in some cohorts exceeds 50%. And among those who survive, permanent functional decline, cognitive loss, and placement in long-term nursing care are widespread. This is never a reason to refuse life-saving emergency surgery when a bowel is perforated and fatal sepsis is setting in. In that acute moment, surgery is necessary to preserve life. What the clinical data proves, however, is that your survival and recovery from an emergency operation are heavily dictated by the physical reserve and planning you established long before the emergency ever occurred. The single most powerful intervention for surviving an emergency surgery does not happen in the emergency room. It happens months and years prior. Maintaining your muscle mass and physical stamina to maximize your physiological reserve. Keeping your blood